The renal system now. It's time to talk about the kidneys, y'all. The first thing we have is glomerulonephritis. And anytime you see the word nephritis, think kidney. It is acute and it can lead to chronic. It's an inflammatory reaction in the glomerulus. It's an inflammatory reaction in the glomerulus. Antibodies lodge in the glomerulus and you get scarring and decreased filtering. So, are your kidneys working correctly now? No, the kidneys are not working correctly. Now, what is the main bacteria that causes this? Strep, a streptococcal infection. Any form of strep. So, if you had a sore throat or something like that, could it lead to glomerulonephritis? Yes, it could. That's why we always emphasize when somebody has a strep infection that they need to be sure and take all of their medicine, even if they're feeling better, especially with strep infections, because strep loves to attack two organs. What are the two organs that strep loves to attack? Heart and kidneys. Heart and kidneys. Now, speaking of the heart, when strep goes after your heart, in what particular part of the heart is it going after? The valves. It's going after the valves. So now I could have some valvular heart damage, right? Yes. Now, what's the purpose of a valve? To prevent backflow. The purpose of a valve is to prevent backflow. Okay? So now then, if you ever get a question about any type of valvular heart disease at all you've got to think about is congestive heart failure, because I guarantee that's where the question will be coming from, or that's where the question will be focusing. Valvular heart disease, think CHF. Now, back to the kidneys. Signs and symptoms of glomerulonephritis. Well, sore throat that might be how it started. Malaise and headache. Now, anytime you see a kidney person with malaise and headache, you know they are retaining what? Toxins. They're retaining toxins. Toxins make people feel really bad, so that's why they get malaise and headache. They just feel really, really bad. All right, when your kidneys are not working well, your BUN and creatinine are going to go up. Yes, your BUN and creatinine are going to go up, because are you able to excrete urea? No. Are you able to excrete creatinine? No. Okay, so those levels are going to build up in your blood. All right, now you see sediment and protein in the urine. Well, we already have said that we never want to see protein in the urine, right? Right. Now, but what has happened with the glomerulus here? We have damage to the glomerulus. It has holes in it, so now what can leak out more easily? Protein can leak out now. That's what strep does to your glomerulus. It attacks your glomerulus and holes form, and so now protein can get out. Now, anytime your kidneys are sick, you may have something called flank pain or costovertebral angle tenderness. Costovertebral angle tenderness. And all that is when the doctor taps over your flank area to see if it's tender or not. That's one way they can see how high up into the urinary tract the infection is, okay? Now, the blood pressure is going to go up. Facial edema, urine output is going down. Your kidneys aren't working, so you can't put out anything. Urine-specific gravity is probably going up, because if the patient is putting out anything, it's going to be very concentrated. That's right, it's going to be very concentrated, which makes your urine-specific gravity go up. Now, by looking at those symptoms, I know my patient is going into a fluid volume excess, because can they excrete fluid? No, they can't excrete fluid. That's why their face is swelling. That's why their blood pressure is going up. Okay, so fluid volume excess. Anemia can occur, and out to the right of the word anemia, you see erythropoietin. Now, anytime your kidneys are messed up, and I do not care what it is, it may be a 4-year-old with a Wilms tumor. If it's a kidney thing, there is a chance that your kidneys are not making enough erythropoietin. And if you do not have enough erythropoietin, you cannot mature your red blood cells. That's what erythropoietin does. It helps your RBCs to mature. So no wonder the patient is anemic. Now, treatment. get rid of the strep or whatever the source is, but usually it is going to be strep. The patient may have to be dialyzed. Now, not everybody with glomerulonephritis has to be dialyzed. It depends on how bad of a case you have, okay? Now, if the BUN is increased, what should be done with the protein in the diet? Decreased. Because protein, as you know, makes your BUN go up. Makes your BUN go up. Now, you know that as a general rule with kidney people, what do we do to protein? As a general rule, we're going to decrease protein with kidney people. Okay? Decrease protein with kidney people. Now, what are we going to do with sodium in this person's diet? Decrease it, because we've already said they're in a fluid volume excess, right? Yes, they're already in a fluid volume excess, so I decrease the sodium. Are we going to increase or decrease the carbs? Well, we're going to increase the carbs, because carbs give us what? Energy. Carbs give us energy. They keep us from breaking down protein for energy. That's what we don't want to happen, okay? Now remember, they're also retaining toxins, and toxins make us feel how? Tired, okay. Now, you learned on the first day of this class why they need bed rest, okay? Why did we say? Because we said in bed rest induces diuresis. Bed rest induces diuresis. And diuresis is important because they're in a fluid volume excess, right? So we need to help them get rid of some of that fluid. I know, daily weights, simply because of this. Do we have a fluid volume problem? Yes, we have a fluid volume problem. Do you agree that I know and daily weights are just standard things that you do no matter what with kidney people? Yes, always. Now, how is fluid replacement determined? This is what you need to know. By their losses plus 500 cc's. By their losses plus 500 cc's. Now, we had to add the extra 500 cc's to account for the what? Insensible fluid loss. We added the additional 500 cc's to account for the insensible fluid loss. And when I say insensible fluid loss, I'm talking about the fluid loss that you cannot see, right? Such as sweat, exhalation, and all the body processes that we have that burn fluid. Diuresis usually begins in 1 to 2 weeks after onset, and blood and protein may stay in the urine for months. It's going to stay in there until that glomerulus is completely well. It does take a while for your kidneys to get well. Now, can this go on to renal failure? Yes, that's what we hope doesn't happen, but we have to teach them signs and symptoms of renal failure, okay? So you see some signs and symptoms listed on your handout. Malaise, headache, anorexia, nausea, vomiting, decreased output, and weight gain. All right? Now, part of the reason we get those symptoms is because the patient is retaining toxins, okay? But also the patient is retaining fluid. So toxins and fluid. All right, now let's go ahead and look at nephrotic syndrome. A lot of times people get glomerulonephritis and nephrotic syndrome confused, okay? They do have some similarities, but I want to point out the major difference here. Now, with nephrotic syndrome, you're not just losing a little bit of protein. You're losing a ton of protein. That's the main thing you need to know. They are losing tons and tons of protein, a lot more than you lost with glomerulonephritis. A lot more than you lost with glomerulonephritis. And the other thing about nephrotic syndrome is your patient will be very edematous, and you'll see why in just a second. A lot more edematous than the glomerulonephritis patient. All right? Now, notice the first sentence here. It says inflammatory response, right? Underline the word inflammatory. There are a lot of things that can cause inflammation in the body. I know. Strep can cause this, but see, other things can cause it too. With glomerulonephritis, 99.9% of the time, the cause of glomerulonephritis is going to be strep. But with nephrotic syndrome, it can be strep, but it can be a lot of other things too. All right. So here we go. Inflammatory response in the glomerulus. Big holes form, so protein starts leaking out in the urine. Now the patient is hypoalbuminemic, no albumin in the blood. Isn't protein and albumin the same thing? Yes, they're the same thing. It's a type of protein. Without albumin, you can't hold on to fluid in the vascular space. So where does all the fluid in the vascular space go? The tissue, out into the tissue. So now the patient is edematous. Since all the fluid is going out into the tissue, what has happened to the circulating blood volume? It's decreased. The circulating blood volume's decreased. Well, the kidneys sense this decreased volume and they want to help replace it, so the Renin-Angiotensin System kicks in. Aldosterone is produced and we get retention of what? Sodium in water. Sodium in water. Anytime you're secreting aldosterone, you're going to retain sodium in water. But is there any protein in the vascular space to hold it there? No. So where does all this fluid go? Tissue. So the patient just gets more and more and more edematous. Now when you see somebody with total body edema, what is the proper term for that? Total body edema. It's called anasarca. A-N-A-S-A-R-C-A. Anasarca. A lot of people just say generalized edema, but the specific term we use here is anasarca. Now treatment. Why are we putting this person on bed rest? For diuresis again. Diuretics, same thing. We want to diurese. Prednisone is a biggie, okay? Now, because y'all, what will prednisone do? Decrease inflammation. Decrease inflammation. That's the key. We've got to decrease the inflammation. But you know, now that I'm on prednisone, a steroid, that's going to bring on other problems too, right? But how is it helping? When you decrease the inflammation, the holes in the glomerulus are going to shrink. So what can't get out? The protein can't get out. That's a good thing. I don't want the protein to leak out. But the bad thing is now that I'm on prednisone, I'm immunosuppressed. So now you're going to have to be careful with whom you put in the room with me because I'm so immunosuppressed now. Now, what are we going to do with sodium in this person's diet? Decrease it. If you've already got anasarca, total body edema, you don't want them to take in more sodium. And what are we going to do with the protein here? Increase it. This is the one kidney disease where you can have more protein. This is the exception to the rule because, y'all, is this patient leaking out a lot of protein? Yeah, so they can have more. They might have to be dialyzed to pull off some fluid. All right. Now, another thing I want to mention here is a Lasix and albumin infusion. A Lasix and albumin infusion. Explain to your friend how this would help this patient. Okay, when you give somebody albumin, this person albumin, that's going to pull fluid back into the vascular space. And we went ahead and gave them the Lasix with it because if you didn't give them the Lasix, they would go into a fluid volume excess. That's right, fluid volume excess. Now, renal failure requires bilateral failure because you know that you can live with one kidney. Now, can't you? Yeah. Types, pre-renal failure is when blood can't get to the kidneys. All right? Can't get to the kidneys. Like if I'm hypotensive, can blood get to my kidneys? No. That's why when somebody's blood pressure drops, we're worried because we're not perfusing like we should. We at least want a blood pressure of 90 because you got to have at least a 90 to perfuse vital organs, right? Another thing about perfusion in the kidneys is this. It only takes 20 minutes of poor perfusion for acute tubular necrosis to occur. All right? Now I'll say that again. It only takes 20 minutes of poor perfusion for acute tubular necrosis to occur. So that's why we don't mess around with kidney things, okay? Because the kidneys will die so fast. Now, decreased heart rate. Well, with your heart rate dropped, what just happened to cardiac output? It dropped too. It went down. So you're not perfusing your kidneys. We've learned a lot of things in this class that can decrease your cardiac output. Could a rhythm change decrease my cardiac output? Yes, a rhythm change can decrease my cardiac output too. Now, what if, for whatever reason, I'm hypovolemic? Hypovolemic. Could that affect my cardiac output? Yes, it could, because I don't have as much volume. Now, intrarenal failure. This is when damage has occurred inside the kidney, such as with glomerulonephritis, nephrotic syndrome, malignant hypertension, and diabetes. Now, with malignant hypertension, which is uncontrolled hypertension, and diabetes, you have severe vascular damage. With those two things, you have severe vascular damage, okay? And remember, the kidneys are very vascular. So if you've got somebody with high blood pressure, it's killing their kidneys, okay? It's just like the lady with preeclampsia or pregnancy-induced hypertension. Even that lady had proteinuria because their blood pressure had gotten so high, it had damaged their glomerulus and they were leaking protein, weren't they? Yes. Now, post-renal failure. This can be tricky. This is when urine can't get out of the kidney. It's trapped inside. Like if you have someone with an enlarged prostate, a kidney stone, tumor, ureter obstruction, or an edematostoma. Well, urine has got to be able to get out of the kidney. And if any of those things are happening or occurring, they can't get out, all right? So it's backing up. The urine is backing up into the kidneys, causing renal failure. All right, now, let's pretend for a second that we've got an 18-month-old who just went in for bilateral ureteral stents. Now, we have not studied that specifically in here, but this is what you're going to have to do on NCLEX. You've got a baby who's gotten bilateral ureteral stents. Now, you know what a ureter is, and you know what a stent is, okay? All right. Now, let's pretend that you're taking care of this patient post-op, and all I'm going to tell you is that the urine output has dropped. That's it. Their urine output has dropped. You've got 4 answers on your handout. Look at those 4 answers and then discuss the answer with your friend, and then I'm going to tell you what the NCLEX answer is. Okay. You've probably decided by now that you aren't going to pick the answer reassessed in 15 minutes because we said that was delaying treatment. And we just got through saying that it only takes 20 minutes of poor perfusion, doesn't it, for the kidneys to start to die. So we're not going to wait around on it. We're not going to delay treatment, okay? Now, if you like the answer irrigate, I'm scared because that is a fresh surgery. And as just a basic nursing concept, new nurses should not be messing around with fresh surgeries. It's still too fragile. You could damage the surgery. You could ruin the surgery, disrupt the suture lines, okay? I know you've seen a lot of nurses irrigate things, or patients may have continuous bladder irrigations and that sort of thing. That's different here. You're not going to take a syringe and shoot fluid back up into the kidneys to try to open up the stent. That sounds like a doctor thing to me, okay? All right. Turn from side to side. What about that? Well, if you're thinking about turning from side to side, I know what you just thought in your head. You said, well, I remember turning somebody in the kidney section from side to side. Yes, that was the peritoneal dialysis patient. You're not going to take a little 18-month-old baby post-op and roll them around just because their urine's not coming out. That's peritoneal dialysis. So there's only one option. You've got a baby who's had surgery of the ureter, of the urinary tract, and the urine's not coming out. Is there a whole lot you and I can do to make the urine output increase? No. So call the doctor. Call the doctor. See, you got to identify what the problem is, decreased output, And then you've got to select a safe answer that most directly attacks the problem. I said a safe answer that most directly attacks the problem. There's probably some swelling or something like that going on inside where the urine cannot get out. But I don't even have to know about the swelling. I just need to know that there's something happening that I can't do anything about, and it's an acute situation because it's a fresh surgery and it's your kidneys on top of that. We don't have time to wait. Signs and symptoms now of renal failure. Well, the BUN and creatinine are going to go up. Why? Because you aren't able to do what? Excrete. You can't excrete BUN, urea, and creatinine like you used to. Now, specific gravity. Depending on your urine output, initially, what little urine is coming out is going to be very concentrated. Yeah, initially they'll just be putting out a small amount of this real dark urine. That's very concentrated. So that would make the specific gravity go up because concentrated makes numbers go up, we said. That's right. But you can get to a point with renal failure where you get what is called a fixed specific gravity. A fixed specific gravity where the patient loses the ability to concentrate and dilute urine. They lose the ability to concentrate and dilute urine. For instance, if you drink 3 bottles of water, you're going to have to use the bathroom and your urine is going to become more dilute. Whereas if you go 3 days without drinking anything, your urine will become concentrated. So see, one of the most important functions of the kidneys is to help us concentrate and dilute urine accordingly, according to how much fluid I've taken in or have not taken in. All right? Well, at some point it becomes fixed. And this is when they may do a fluid challenge, all right? Like in acute renal failure. They would not do this in chronic renal failure. This is when they would take a bolus of saline, 250 cc's of saline, and give it to the patient IV really, really fast. Well, most people, you give them a bolus of saline IV, and their urine output's not only going to go up, but that urine is going to be more dilute as well. Yes, it's going to be more dilute. Well, in this person, they bolus them with the fluid challenge, and their specific gravity stays the same. It's a fixed specific gravity. All right, let's move on and talk about anemia. Well, we know that anemia can occur with renal failure because there's not enough erythropoietin, right? We've already talked about that. Hypertension and CHF can occur because we're retaining fluid. Anorexia, nausea, vomiting can occur because what are we retaining? Toxins. Retaining toxins. Now, some people get what's called an itching frost, a uremic frost, unless you're being dialyzed, right? If you're being dialyzed, they're going to be pulling the urea out of you. But if they get the uremic frost, you have to do really, really good skin care. All right? See, sometimes you'll run across a patient who, for religious reasons, cannot be hemodialyzed. So the urea will just build up so much in their blood that it eventually will come out onto their skin. The next thing says acid, base, and fluid and electrolyte imbalances. Now, we've talked about that plenty, but let me add one more thing here. Renal failure people tend to retain phosphorus, so calcium does what? Decreases. So now calcium is going to be pulled from the bones. So now I've got renal failure and osteoporosis. Now we have 2 phases of renal failure. Oliguric is the first one. Think about what that word means to you. What has happened to their urine output? Decrease. They're oliguric. So this patient is in a fluid volume excess. They're retaining fluid. All right? Yes, they're retaining fluid. And what do you think is going to happen to their potassium? Increase. Potassium is going to go up because anytime you're not excreting, you're retaining potassium. So if I ever wrote you a question about the oliguric phase of renal failure, the 2 major things I would have to ask you about would either be fluid volume excess or hyperkalemia. Fluid volume excess or hyperkalemia. Now, the diuretic phase is next. Well, what is happening to the urine output here? It's increased. This patient is in a fluid volume deficit, which can lead to shock. They're just really diuresing, losing a lot of fluid. And what do you think is going to happen to their serum potassium? Decrease, because they're excreting it, aren't they? Yes, they're excreting it. Now, hemodialysis. The machine is the glomerulus, and as you know, the glomerulus is your filter, right? Right. Now, if the patient is allergic to heparin, they can't be hemodialyzed. If they're allergic to heparin, they cannot be hemodialyzed. You see, the procedure of dialysis is very turbulent, isn't it? Yes. And anytime you've got turbulent blood flow, there's always a chance that a clot can form. So they heparinize the machine and the patient to decrease the chance that they do get a clot. Now, this, what I've just been over, is a generally accepted standard across the country. All right? That's a generally accepted standard. But if the patient is allergic to heparin, hemodialysis can be done if the hospital has the other solutions they're supposed to have with an anti-clot property like cath flow. But not all nephrologists and not all hospitals use that. So the standard we start with is if they're allergic to heparin, they cannot be hemodialyzed. Now, you won't, on a test, you won't be tricked by anything like that. If they've got cath flow at the hospital, they'll let you know they've got cath flow. All right? Now, hemodialysis is done 3 to 4 times a week, so the patient has to watch what in between treatments? What they eat and drink. What they eat and drink. Now, do you agree that the lifestyle of a hemodialysis patient is very confining and depressing? Yes. And suicide is a possibility. And one of the ways they commit suicide is they eat something they're not supposed to have. So like bananas. What if they ate too many bananas? What would that do to their serum potassium? Make it go up, and then they get a life-threatening arrhythmia and die, right? Yes. Electrolytes and blood pressure are watched constantly during the procedure. And can all patients tolerate hemodialysis? No. Some people, every time you try to dialyze them, they go into shock. You see, if you've got somebody with a real unstable cardiovascular system, they're not going to be able to tolerate hemodialysis because are we taking out a lot of their volume? Yes. Now, you must also have a circulatory access, and that might be an AV shunt, a fistula, a graft, or a temporary catheter, like an ASH catheter. Okay, that's just a specific type of temporary catheter. Now, this catheter is used for short-term access while the permanent access matures, which usually takes about 90 days or less, okay? It's the doctor's decision as to which one of the circulatory devices they're going to use, okay? Now, be sure and remember, do not use any of the circulatory accesses that we have listed on your handout as IV access sites, okay? The most important thing for you and I would be the next statement. When a patient has an alternate circulatory access, what is the associated nursing care? Okay, well, I don't want any blood pressures. No needle sticks. No constriction on that arm. No constriction on that arm at all. So I don't want them to wear a watch on that arm. I don't want them to have a blouse on that has elastic in the sleeve. I don't want them to carry their purse on that side. No constriction on that side at all. Because you don't want anything to impair circulation to the alternate circulatory access device. Okay? Now, you may palpate the device, okay? And when you palpate it, you will feel a thrill. You will feel a thrill. That is the cat purring sensation. Cat purring sensation. All right? And should it pulsate? Yes, it should pulsate. And when you auscultate it, you will hear a bruit. You will hear a bruit. So you feel the thrill, hear the bruit. The next thing we have is peritoneal dialysis. And this is when the dialysate is warmed and infused into the peritoneal cavity by gravity through a catheter. Now the fluid, which is about 2,000 to 2,500 cc's at a time, milliliters at a time, stays in for an ordered amount of time, okay? We call that the dwell time. Then the bag is lowered and the fluid along with the toxins are drained. So we're draining out all those toxins. Now why do we warm the fluid? Well, cold fluid would promote vasoconstriction in here. We don't want vasoconstriction in here. That will limit my blood flow. And if you're limiting the blood flow, you're not pulling off many toxins, right? Right. We warm the fluid to promote vasodilation. We warm the fluid to promote vasodilation and more blood flow. That's going to get more blood flow going to the area so more toxins can be pulled out. Well, what should the drainage look like? Clear, straw-colored. Clear and straw-colored. If it were cloudy, I would have to assume what? Infection. You should be able to read a newspaper through the drainage or effluent. Now, what type of patient gets peritoneal dialysis? Somebody who can't take hemo. Somebody who can't take hemo, like the person who had the unstable cardiovascular system. Now, what if all of the fluid doesn't come out when you lower the bag to the floor? All right, what you going to do? That's when you reposition your patient or turn them from side to side. Reposition or turn from side to side because we want all of those toxins to drain out. Okay? Now, there are two types of peritoneal dialysis. The first one is Ccpd, which stands for Continuous Ambulatory Peritoneal Dialysis. All right, let's talk about, we're going to talk about CAPD. The second one we have listed for you is Ccpd, which stands for Continuous Cycle Peritoneal Dialysis. The patient connects their peritoneal dialysis catheter to a cycler at night, and the patient does their exchange while they are sleeping. So, and it's disconnected in the AM. So the patient has more freedom with that. All right? Now, CAPD. Again, this is a type of peritoneal dialysis. Now look at the kind of person you've got to have here. You must have a semi-strong patient that has the energy and desire to be active in their treatment and that also has the ability to learn and follow instructions. So is this for everybody? No. It's done 4 times a day, 7 days a week. Is an exchange done at night? Not usually. They can if they want to, but they don't have to because they've been performing the procedure all day long. Now, could a patient with disc disease or arthritis do this? No, because the fluid causes pressure on the back. Pressure on the back, okay? People that do this procedure always complain of back pain or discomfort. Always. It's just a part of it. Could a patient with a colostomy do this? No, because the risk for infection would be too high. High risk for infection. You wouldn't want a stoma that close to your peritoneal catheter because your peritoneal catheter is sterile, all right? Complications. There's a very high risk for infection. Anytime you have a sterile catheter going into your peritoneum, there's always a risk for infection. So the number one complication is peritonitis, okay? Now, signs and symptoms of peritonitis are abdominal pain and cloudy effluent. That could be the very first sign, all right? And if you had a patient who had a colostomy that close to their peritoneal catheter, I guarantee they're going to have peritonitis. Also, constant sweet taste because the dialysate is so full of glucose, right? It's a hypertonic solution we're putting in here, and what's making it hypertonic is all of that glucose that's in the solution. Now, as a rule, all that glucose usually does not affect your blood sugar, but it can. We need to be checking the blood sugar just to make sure. And also, like I said, if you've got that sweet taste in your mouth all the time, that can also affect your appetite, anorexia. The patient may get a hernia because of all the pressure in the peritoneum. They're probably going to have an altered body image and sexuality because of the altered body image. And what do you think is going to happen to their abdominal muscles? Yeah, their abdominal muscles get all stretched out. All right? Now there's low back pain again. That's because of all the fluid inside. What are we going to increase in the diet? Well, there are two things. One is fiber, because they have decreased peristalsis due to the abdominal fluid. They have decreased peristalsis due to the abdominal fluid, so they have trouble with constipation. I always have trouble with constipation, so they need more fiber. And then protein is needed for this person. Protein. Because in your peritoneum, you've got big holes. So every time this person does an exchange, what are they losing? Protein. So here's you another kidney person that can have protein. The next thing we have is continual renal replacement therapy. CRRT. A Prisma is the name brand of the kidney, the filter that is utilized in many facilities, okay? CRRT is typically done in an ICU setting, and it's performed on patients whose cardiovascular status is very fragile. You know, we've already said that certain people have trouble with hemodialysis because the fluid shifts are so great. Hemodialysis is much more aggressive. With hemodialysis at any given time, they may have 300 milliliters of the patient's blood in the machine. But however, with CRRT, there is only approximately 80 milliliters of the patient's blood in the machine at any given time. Now, another thing we need to talk about is something called ultrafiltration. Sometimes you'll hear a doctor come in the room and say, okay, we're just going to ultrafilter you today. Ultrafilter. And what that means is we're just going to be pulling water off of the patient. Free water. I did not say pull sodium in water. I said pull just the water off of the patient. And the same principles as with hemodialysis are applied here. Okay? All right, let's think about this for a second. Let's pretend you've got that scenario I just mentioned, where the doctor comes in and says, you don't need hemodialysis today. We're just going to ultrafilter you. We're just going to pull excess water off of you, okay? Because all of your electrolytes are normal except for one. And I can tell by looking at your electrolytes that you're full of water. What's the one electrolyte that's messed up? Sodium, because that's the only electrolyte that cares about water, right? Right. Now here's the tricky part. Is our patient at this point in time, when they're full of water, hyponatremic or hypernatremic? Ask your friend. If you're full of water, your serum sodium is going to go down because dilute makes numbers go down. So our patient is hyponatremic. Hypo. See, you're still thinking nursing schooly if you're saying, well, sodium follows water, water follows sodium, because they don't always follow each other. That's why I was emphasizing that they were just retaining water and they were going to pull off just the water. Okay. Kidney stones. Also known as urolithiasis, okay, or renal calculi. Signs and symptoms. Pain is the first thing everybody thinks of when they think of a kidney stone, all right? And the pain can be so bad that it can lead to nausea and vomiting. Now, you can have white cells in the urine, but put a big star by hematuria too, all right? Now, I got you a little scenario here I want you to think about. Ask your friend, which patient would you go see first? And I'm not going to give you much data here because I'm really going to put you in a bind. You just got to work and you just got out a report and you've got two patients. One is a patient who's been admitted for a kidney stone and they're having gross hematuria, and another patient whose blood pressure is 90. Now you decide which patient you're going to go see first. What you think? How many times have you read about a kidney stone and it said that they were fatal? Never. Kidney stones don't kill you. The patient thinks they're dying because the pain is so great. Okay? And I said gross hematuria, but you've got to use some judgment. And you know the amount of blood that they're losing with a kidney stone is not enough to throw you into shock. The patient whose blood pressure is 90 may be the one that's in shock. Now I know what you're saying. Well, my blood pressure's 90 and I'm not in shock. It doesn't matter. We don't know these patients. Well, so what you're going to do is you're going to go to the room first where the blood pressure is 90. That's what they told you in report, that the blood pressure was 90. You go in there and look at that patient. If they're sitting up in the bed flipping the remote eating Cheetos, you can tell them, I'll be back in a minute, and then go to your kidney stone patient. All right? That's how they get you on boards. Now, anytime you suspect a kidney stone, we need to get a urine specimen as soon as possible and have it checked for RBCs. If RBCs are present, then it's probably a kidney stone and the patient will get pain medicine. My point is this. You don't waste time. You don't let people lie around with kidney stone pain for a long, long period of time. Okay? Most of the time, when people with kidney stones come to the ER, they don't even stop at the triage desk. Now, do they? No, they just walk straight on back to their room, all bent over, hurting really, really badly, telling you to hurry up and get their pain medicine. These people know what they're having as a rule, because do kidney stones have a tendency to reoccur? Yes, they have a tendency to reoccur. Now, the treatment, Toradol or Dilaudid. Toradol or Dilaudid, and it says on your handout to increase fluids. Now, is this true during the acute stages or forever? Forever. They need to drink lots of fluids because we've already said that kidney stones do have a tendency to reoccur. And yes, they may have to do surgery. And yes, we're going to strain the urine. And they may do an extracorporeal shock wave. That's lithotripsy, okay? To crush the stone. Most people just say lithotripsy. And this is when high energy shock waves are passed through the body and used to break the stone into pieces as small grains of sand, okay? And because of their small size, these pieces can pass from the body along with the urine. So when a patient comes back from their lithotripsy, they might have a Foley, all right? If they do have a Foley catheter, what might you see at the bottom of the Foley drainage bag? Sand. That's the crushed stone, isn't it? That's a good sign. That means that stone is coming out. All right, enough on the renal system.